introduction. So I am a board certified urologist. I've been in practice for 8 years, but I've been a physician much longer than that. My urology training was at University of Cincinnati from 2008 to 2013. During that period, I did publish quite a bit of research, and one of those research was on MRI of the prostate. It was one of the earliest papers to look at MRI for targeted biopsy of the prostate, which back in 2010 to 2012 was when the study was done. Now it's almost routine practice, but at that time, this was one of the earliest papers to publish on that. Following residency, I went to University of Minnesota to do a fellowship in genitourinary trauma and reconstruction. And as part of that, I gained extensive experience in implantation of artificial urinary sphincters and penile prosthesis. The other experience I had, which was kind of unfortunate, but still it was a good experience to have, was in repairing radiation-induced injuries to urethra and bladder. My current practice is pretty heavy in treating genitourinary cancers, including prostate cancer. My practice involves quite a bit of MRI fusion biopsies. I have a good number of patients on active surveillance. We are starting to do what are called transperineal biopsies, which are biopsies that are done through the perineum, that is the area between the back of the scrotum and the anus, instead of going up through the anus, which is called the transrectal biopsy, which probably almost all of you have had. I do a lot of robotic surgeries for prostate cancer, kidney cancer, bladder cancer. One of the more high volume robotic surgeons in the area, doing at least 100 of those a year. I also do a fair number of prosthesis, mostly penile prosthesis, which averages about 2 of those a month at least. So that's a brief introduction of what I do. So starting off, and I'm going to keep this very simple and very brief. I'm not here to overload you with data and information. I want to save as much time as possible for questions. So why active surveillance? What is the rationale behind active surveillance? What we know is that even though prostate cancer is the most common solid organ cancer in men, not all prostate cancers are lethal. And about at least 30% of them are what we call as indolent or lazy, meaning they just sit there and don't do anything. And thanks to the work of several researchers, physicians, urologists who came before me, we know this information. And this is true especially of what are called very low risk and low risk prostate cancers, which are the Gleason 6 prostate cancers and the kind of Gleason 7, which is called Gleason 3+4. Now we have a new system for grading prostate cancers. Patients were always confused. Why are you starting the scoring from 6? Why is it 6 to 10 and not 1 to 4 or whatever? Well, now your prayers have been answered. Now the prostate cancers are graded as Gleason group 1, Gleason group 2, Gleason group 3, and Gleason group 4. The Gleason 6 and Gleason 7 belong, or Gleason 3+4 belong to the GG1 and the GG2 group, sets of grades. So the good thing about the new grading system is that a score of 6 would seem high if I told someone that they have a Gleason 6 prostate cancer. 6 out of 10 would seem high. But then when we tell them that it is a Gleason group 1, now that scoring seems lower when compared to the number 6. So, I think it has clarified things a lot, both for urologists as well as patients. We are transitioning slowly and surely away from the Gleason 6, 7, 8, 9, 10 to a GG 1, 2, 3, 4. So coming back to the prostate cancer, we know that not all prostate cancers are lethal. About a third of them are lazy prostate cancers. And treatment for prostate cancers can and do have side effects. And these side effects can be sexual in terms of effects on erections. The side effects can be urinary in terms of, urination symptoms. They can also be psychological. And these side effects can affect the quality of life of men and indirectly their partners. So the big question is, even though there are treatment options, are these necessary? Is treatment of the prostate cancer necessary for certain types of it? And so the treatment of the lazy or indolent cancers, whether it be by surgery or radiation, which are the gold standard of treatment, can be overkill. So that's where the whole concept of active surveillance comes from, which is, let us not do any treatment for the cancer right away, at least. Let us watch the numbers. Let us monitor the PSA and other criteria, as I'll talk about. And at any time that it seems like the cancer is misbehaving, we will always be ready to pull the trigger, so to speak. So what is active surveillance? It is active monitoring of certain types of prostate cancer. Again, I want to make the point here that not all prostate cancers are amenable to active surveillance. And even among Gleason 6 and Gleason 7 or GG1 and GG2 cancers, there is a subset of it which are good for active surveillance. So the GG1 and GG2 are called favorable risk, meaning that the likelihood of these cancers misbehaving over the intermediate or even long term is very low. So these cancers are the ones that are statistically not likely to worsen or spread outside the prostate as long as certain parameters are met. And even in my time doing urology, which is, comparatively, it's not very long, but it is long enough. I have seen several criteria come and go. Back in, say, 2010, we were mostly going by the PSA, patient's PSA, what the transrectal ultrasound biopsy showed, and then subsequent PSA numbers, because we did not have the luxury of doing MRIs at that time, for example. And we did not have data. The data was just starting to come in. So about 10, 12 years later, we have a wealth of data on active surveillance. And there are two criteria that are almost, consistent. As long as the PSA density, which is how much PSA does your prostate make per ml of prostate, right? So the PSA density is being less than 0.15 is one of the criteria that stand out across every good study that has been done on active surveillance. As long as the PSA density is less than 0.15, the chances that the cancer is going to spread outside of the prostate is very low. Less than 1% over 10 years. And less than 20% of a biopsy core involved with cancer. And I've given the link to the study from 2019. And this is just one of the studies. There are several of these that reinforce these two criteria. And now that we have the benefit of doing MRI, as long as the MRI does not show, the initial MRI does not show any suspicion of the cancer coming close to the prostate capsule or getting outside of the prostate capsule, that is a criteria that more and more we are using for active surveillance. So again, PSA density less than 0.15. So if someone has a 60 ml prostate, a PSA of less than 0.15 would mean a PSA of 9 or less, right? At 9, the PSA density would be 0.15. So you can make the calculation if you know your prostate volume and what your PSA is. So aim is to avoid treatment while at the same time monitoring for any signs that the cancer could be getting worse. And again, the aim is to intervene at the earliest sign where the cancer becomes unfavorable. And the intent always is to cure the patient of the cancer, which is different from what we call watchful waiting. Watchful waiting is where we let the cancer go until it is metastatic or causing symptoms. And at that time, the intention is not to cure, it is to give medications like Lupron to keep the cancer from getting much worse. So that would be almost what would be called a palliative treatment, not a curative treatment. So that's a big difference between what active surveillance is and what watchful waiting is. In active surveillance, the intention is always to cure the cancer, but to wait until the cancer shows signs of getting worse. And at every point, this is a shared decision-making between the patient, his partner, and the physician. I believe that, the spouse, significant other or the caregiver has to be involved in the decision-making. And that is more by me kind of realizing that as men, we tend to kind of hide a lot of things or not take things sometimes too seriously. And the women folk in our life tend to be truly the better halves in terms of decision making, especially in terms of health. So involvement of the partner is very important in the decision making. So as I said, even in the last 10 years, even in the last 5, the concept of active surveillance, how to do it, what criteria to use, these things have evolved quite a bit. So many more tools are available today for monitoring and for risk stratification. PSA was always there. Now we know about PSA density. Once the diagnosis of prostate cancer is made, then things like free PSA and those kinds of things really do not matter as much. So PSA density does matter. MRI of prostates are done almost routinely now. It has become the standard of care in most places. And with MRI, we can continue to do active surveillance to see what the real picture of the prostate looks like, what the cancer looks like from an imaging standpoint. To give you an idea, if someone went on active surveillance, say back in the 2010s, they would get PSAs every 3 months. And every time PSA went up, the patient would be subject to a biopsy. So a lot of patients may go through 1 or 2 biopsies a year, and the results would turn out to be the same. But now with MRI, if the PSA goes up, even if it is the density is say, at or a little above 0.15, I can get an MRI, make sure that if there is a suspicious lesion that I've seen in the past, I can make sure that the spot remains the same and has not changed much. then I can confidently tell the patient, you know what, we can wait, check another PSA in 3 months or 6 months and take it from there. So the MRI has helped us to get real-time pictures of what the lesions look like and avoid a lot of biopsies. But also, if there are newer spots, if the previous spots are getting bigger or coming closer to the capsule of the prostate, now it might be time to have a discussion with the patient about, look, we know there is cancer. We can look at the MRI and we can say that this is getting bigger or coming closer to the outside of the prostate. We can go ahead and do another biopsy, or we can make a decision regarding treatment. So, the MRI has helped us avoid a lot of unnecessary biopsies. And even in terms of biopsies, using the MRI to do what are called fusion biopsies has helped us to be more accurate. The routine transrectal ultrasound biopsy is, for lack of a better comparison, it is like going fishing. You drop the reel in and you are hoping that something will bite, right? So the transrectal biopsy is, yes, we see where the prostate is, but beyond that, we really don't get much of a idea of where any small lesions or suspicious lesions are. All that the ultrasound tells us is, here is your target, or here is the prostate. But with the MRI, we are able to zoom in on any suspicious lesion. So our biopsy yield is much better. And then there are genomic testing where the prostate biopsy specimen can be tested to see if there are any aggressive features in it. And I'll talk about genomic testing in a little bit. So these are all the tools that are available as of today, which were not there 5-10 years ago. We are not, as urologists, we are not dependent on digital rectal exams anymore. This is, again, kind of a paradigm shift from, 5-10 years ago. Digital rectal exams, some patients of mine get upset when they come in and they don't get a digital rectal exam. What I tell them is that my finger is only this long. And by the time it goes in through the anus, there is only the last tip of the finger that is useful for me. So I'm only feeling the very tip of the prostate in most men. But there is a lot more of the prostate, like the tip of the iceberg. There's a lot more of the prostate that's ahead of me. And I have no idea what it will feel like or what is going on in there. And all I know is all I'm feeling is the outside of the prostate. I don't know what is going on the inside of the prostate. So a digital rectal exam is inaccurate. It can be misleading. Just because a prostate feels quote unquote fine does not mean that everything inside the prostate is fine. So we are almost given up on the rectal examination of the prostate as a way to monitor what is going on, either as a way to diagnose cancer or to monitor it. Okay. So the other thing that is evolving in terms of active surveillance is that we are able to offer active surveillance to a very selected group of patients with intermediate risk disease, what is called Gleason 4+3 or Gleason grade group 3 disease. So we are starting to offer, with the aid of MRI and PSA density, we are starting to offer active surveillance for men with Gleason 4+3 disease. I think I have 3 or 4 patients as of now who have Gleason 4+3 or an active surveillance. The other thing that we know is that race and family history of prostate cancer does not disqualify a man from being an AS candidate. We used to think earlier that if someone had a family history of prostate cancer, that the cancer would behave more aggressively in those men. That the data that has come out on that says unequivocally that no, that is not the case. Just because someone has a family history of prostate cancer does not mean that he would not be a candidate for active surveillance. Also, we used to the prevailing thought was that African American men are at higher risk of progression of prostate cancer, uh, death from prostate cancer, which I disagree with. But again, the data has shown that no, race does not play a part. And there's also more awareness about the mental health component of active surveillance. We used to sign people up for active surveillance without knowing what happens to their anxiety levels, to their, does it play any role, for example, in insomnia, just self-care, things like that. But with evolving data, we know that, finding out about underlying mental health issues is also important while, getting someone signed up for active surveillance. So again, as I said, the paradigm of active surveillance has been evolving over the last decade, and it is still evolving. I'd say it is close to being mature, but not there yet. And different people or different, even institution-wise, there will be different ways of doing it. Certain basic things are common, for example, monitoring PSA and things like that. But there are some nuances which are dependent on the patient. Sometimes, certain urologists may do certain things while others may not. But as long as the basic things are done, those little nuances really do not matter a whole lot. The way I do it, I like to get MRI upfront. A patient comes to me with a diagnosis of elevated PSA. If it is truly elevated for age, I like to get an MRI upfront. As I mentioned earlier, it helps us do more accurate biopsies. So I like to get an MRI and do a fusion biopsy upfront. Of course, insurance being insurance, not everyone's claim is accepted. So if I'm unable to get an MRI and the first biopsy is a transrectal, the regular biopsy, and the result comes back as Gleason 6, GG1, or Gleason 3+4 GG2 disease, which I think is good for active surveillance, I would get a follow-up MRI and do what's called a saturation biopsy. This is something that would be done. I do the prostate biopsies. If it is just the routine biopsies, I do them in the office with just local anesthesia. But if I have, so the next step, if the first biopsy is just a routine transrectal ultrasound biopsy, would be to get the MRI, take the patient to the operating room, put him under some sedation, and sample more of the prostate just to make sure that I'm not missing any significant cancer that might disqualify that man from being an active surveillance candidate. And if the MRI shows any suspicious spots, of course, those are also going to be included in the biopsy. And then when I have the discussion, as I mentioned earlier, I always encourage the spouse, significant other to be present while discussing biopsy results. And whether it is Gleason 6, Gleason 7, unless it is a really bad, 8, 9, 10 cancer, I tell the patient and the family that you have time to make your decision. You don't have to make the decision right now, today, while you're sitting here in my office. You can go home. I always send them home with a book on prostate cancer. I tell them you have time to go home, think about your options, and call me with your decision. If you want to continue, if you want to do active surveillance, great. Here is the plan. This is when I'm going to see you next. If you want surgery, we'll meet again and talk more about surgery. If you want to have radiation, I can send you to a radiation doctor. If you want something like HIFU, we can talk about that also. So there is, from my standpoint, there is never pressure on the patient except under certain criteria when the disease is really aggressive to make the decision right then and there. I do not use genomic testing, testing like Prolaris, Decipher, etc., for Gleason 6 disease. I use it when doing active surveillance for Gleason 3+4 disease. Even then, not for everybody. The reason why is because genomic testing gives the statistical probabilities. What are the chances that this cancer could be aggressive? As in, what are the chances that it could metastasize in 5 years or in 10 years? What are the chances that there could be cancer outside the prostate? So it gives possibilities, not a sure number. And there is no cutoff. For example, if the probability of metastatic disease or the cancer spreading out to the rest of the body in 5 years, say is 25%, what does that mean, right? Yeah, of course, I mean, 25% is worse than 1%, but it is better than 50%. So again, it gives the probabilities, but there is no comparison, right? The only comparison I have is I can say that if someone is on active surveillance and they meet all the right criteria, the chances of metastatic cancer is less than 1% over 5 to 10 years. That is the only comparison I have. But using PSA density, Gleason score, MRI, percentage of core involvement, I can come to the same numbers as doing genomic testing. So I find genomic testing to be not of much value, except, as I said, in certain cases of 3+4 cancer or GG2 cancer. And I always ask the patient, are you going to be able to sleep peacefully with the decision that you've made? Because as I mentioned before, we want to take the mental health of the patient under consideration. It is important for the patient to feel comfortable with the decision to do active surveillance. I offer them counseling, mental health counseling if they need it. And I always emphasize to the patient that he can change his mind at any time. They're not bound to be on active surveillance. There is no contractual obligation. At any time that the patient feels that he is not comfortable, he can choose to have the very many options of treatment that he has in front of him. And then how I do it, for the first 2 years, I get PSA every 3 months. If the PSA remains stable over 2 years, I'll space it out to every 6 months. If the PSA goes up, I don't have this knee-jerk reaction of doing a biopsy immediately. I'll recheck it after 4 to 6 weeks. I'll tell the patient avoid intercourse for 48 to 72 hours prior. And then if the PSA is still up on a second time, I'll first do an MRI, unless the MRI has only been, say, 3 months ago or something like that. And if the MRI is reassuring, there are times when I won't do a biopsy. It all depends on how much the PSA has gone up by. If 2 successive PSAs show a continuous rise, the PSA density has gone over 0.15, the MRI shows a worrisome change, I'll then do a rebiopsy. I do the MRI regardless of what's going on with the PSA. I'll do an MRI yearly for the first couple of years. And after that, it all depends on what the PSA looks like, what is the age of the patient. There are several criteria which I tailor to the patient. But more often than not, even if the PSA remains stable, I'm getting an MRI every 2 years after the first couple of years, because as we know, PSA is a good test regardless of what you may have heard, but it is still not a 100% accurate test. Okay. And as I said, anytime the PSA rises, I'm getting an MRI is my go-to more and more. I continue to monitor urinary symptoms, sexual function, and mental health. A lot of men have enlarged prostate and urinary symptoms because of just by the virtue of having an enlarged prostate. If urinary symptoms are getting worse, medications are not working anymore, then it's probably time for treatment, either in terms of removing the prostate, and we can get into the weeds here, but there are times when we can also do a newer form of TURP called holmium laser enucleation of prostate, which removes almost all of the prostate, leaving just the shell behind. And it has been shown to work for urinary symptoms and not make the cancer any worse. We can, I can answer questions about that if someone has later. Again, the other reason to do surgery is that the patient's mental health is getting affected, or treatment, not just surgery, treatment. So the take-home messages for active surveillance. Active surveillance is safe in well-selected patients. It may not be suitable for everybody, but the risk of cancer metastasizing and becoming incurable is less than 1% in 5 years. It is suitable for men of all ages. We used to say, don't do active surveillance it would just be an arbitrary cutoff 5-10 years ago. Well, let's not do active surveillance for somebody less than 60. And my question was why? And again, that has been shown in studies, especially the one that I just quoted about 3 or 4 slides ago, that active surveillance is safe in younger men less than 60. Younger men can maximize their time of peak sexual function. Of course, the chances of them needing surgery during their lifetime, I keep saying surgery because that's what I do, but the chance of them needing treatment during their lifetime is much higher. But as long as it is being monitored, as long as we are doing active surveillance, the cancer is not going to get out of hand. It's not going to become incurable. Okay, but the patient can use 5 years, maybe even 10 years of retaining their sexual function, and while at the same time not letting the cancer get out of hand. Older men have the best chance of avoiding treatment altogether. There's a common saying in prostate cancer that one is more likely to die with prostate cancer than of prostate cancer. And it is even more and more true in today's age where there are newer agents, newer forms of treatment. I said before, it's a shared decision-making. The onus is on you as the patient to ask your urologist. Once the diagnosis of cancer is made, the onus is on the patient to ask if active surveillance would be right for you. Get a second opinion, maybe even a third opinion. You don't need to make a decision right away. If there's the first time you're getting the diagnosis of prostate cancer and you think you might want to go down the path of active surveillance, but your trusted urologist is not agreeing with that, there is no harm in getting a second opinion. I don't take offense to a patient of mine getting a second opinion. I don't think any urologist or any doctor for that matter should take offense to that. Involve your life partner because they are as much involved in the care and in this process as you are. And again, know that you can change your mind at any time. There